We'll give a presentation first, and then we'll open up the floor for questions after. I want to introduce Dr. Kevin Guskowitz with UNC Chapel Hill. Kevin is a Keenan Distinguished Professor and Founding Director of the Matthew Guilford Sport-Related Traumatic Brain Injury Research Center, Center for Study of Retired Athletes. He also serves as the Chair of Exercise and Sports Sciences at UNC Chapel Hill. He has joint appointments with Orthopedics, UNC Injury Prevention Research Center, and a doctoral program in Human Movement Science. He's been involved with concussions over 17 years. He has multiple publications and presentations and grants. He is also a fellow in the College of Sports Medicine, also an Academy of Kinesiology and the National Athletic Trainers Association. In September 2011, he received the MacArthur Fellowship, which is given annually to individuals who show exceptional merit and promise for continued and enhanced creative work. So without further ado, I give you Dr. Kevin Guskowitz.
Great. Thank you, Michelle. So it's a pleasure to be here, and I really want to thank Michelle for the invitation and her patience, because we tried to work this out at least 2 or 3 years in a row, and such a pleasure to be here. And I'm sure it's always this warm and sunny in Morgantown, West Virginia on March 22nd. That is what you told me, right?
Yes. Yes.
But I also great to see some familiar faces in the crowd. I've seen Ray Adams, a good friend of mine from our days back at Pitt. It's probably been 15, 20 years since I saw you, so it's great to see some familiar faces. So what I want to do is sort of walk you through some of our research, talk a little bit about how we bridge the gap between research and clinical practice, and then we'll save some time at the end for questions. So we've been very fortunate at UNC Chapel Hill, and I know you have an outstanding sports medicine program here in West Virginia as well. We really believe in conducting clinically applicable research. We use our playing fields, our athletic training rooms, our clinics as a laboratory, and I think that's what makes our work unique. Unlike an emergency room physician that doesn't have a baseline on what someone looks like prior to their injury when they come into their emergency room, is the sound, is it too loud? Can you hear this okay?
You can turn it down some.
I've seen Dr. Nugent shaking his head. Is it too muffled? No, we're good? Okay, good. So I want to, we have the benefit in our setting of having information about these athletes before they're injured. And so I think that makes our setting unique. Our work has focused, originally my work focused in the sort of neuropathology, looking at the neurophysiological changes after concussion, tracking recovery curves. More recently, we've been looking at the biomechanics of concussion, and I'll talk a bit about this. More recently, with all the state concussion laws, looking at education and awareness and trying to convince athletes, parents, coaches, they need to take this injury more seriously. So we're working hard on this venue as well. And then behavior modification. I'm going to show you some of the work we've been doing, how we're changing the behavior of athletes to try to prevent concussive injuries. Helmets alone cannot prevent these injuries. In fact, they do very little with preventing the actual concussive injury. They do a great job of preventing the more catastrophic injuries. And then treatment and rehab. This is another area that sort of is, we're trying to develop techniques to rehab individuals with concussion. So this is my setting. This is where I work. This is the Stallings Evans Sports Medicine Center. It sits in the heart of our campus at Chapel Hill. This is inside that center where we're rehabilitating an athlete following concussion. I often say that we try to bridge the gap between what happens in the laboratory and what ultimately is translated off to the field then. And we're also working out with a lot of high schools in the area in terms of trying to put better tools in the hands of our athletic trainers and team physicians. Our center is named Matthew Gefeller Sport-Related Traumatic Brain Injury Research Center, named after Matt Gefeller. Matt died on a football field in Winston-Salem, North Carolina in August of 2008 as a result of a massive epidural hemorrhage that he sustained. Was probably not a preventable injury, one of those rare, very rare injuries that takes the life of an athlete. But his parents wanted something positive to come out of Matt's lost life, and they decided to raise money to name our center after Matt. And so I always sort of try to mention Matt and his family because they're doing amazing things to try to help prevent these sort of injuries from occurring in the future. And this is just some of the work I'll talk about today. Involves helmet accelerometers that we use. And, we have an undergraduate program, a master's program, and a doctoral program in sports medicine. And a lot of the focus is in our area of sport concussion. So a lot of our work involves teaching and training of clinicians and students to do this work alongside us. If you're wondering what this crazy looking device looks like, this was developed by NASA. It's called a Neurocom Equitest, and it puts athletes or patients into an environment where the visual surround moves, the walls move, the floor moves. We try to recreate a setting in which their vestibular system is disrupted to see if they can accommodate for this through vision and somatosensory inputs. And it was developed by NASA because back in the late 60s, early 70s, when the astronauts were coming back from being in a weightless environment for a lengthy period of time, they were having all sorts of balance problems. And so they developed this to see if we couldn't retrain them after they've come back. And we took this system about 12, 14 years ago and have used it to try to validate some return to play evaluation protocols to assess concussion and make better return to play decisions. So I'll share a little bit of that with you as well. I want to just touch on a few headlines. I think it's, in terms of capturing the audience's attention, it's always good to talk about this injury, sport concussion. And we've seen far too many headlines on this topic over the past 5 or 6 years. And this is one that just after 2010, after the NFL's concussion committee put into place some very rigid return to play guidelines, mandates by the commissioner's office on this injury. We had this take place, and I have the headline up there, or the title of what went wrong here, but I want you to watch this injury. This is Stephen Bradley is down. He's a linebacker for the Philadelphia Eagles, and you're going to see the play here in a second. So this is just after his hit. You can see his player is waving on. Watch him hit his head here. Sort of gets a face mask planted into the knee of his own player there, a teammate. Sort of a hyperextension injury, difficulty getting up. But what went wrong here? Does anybody know what transpired after that? Went right back in. 4 minutes of real time on the clock went right back into the same game. And so the team's medical staff was criticized for mishandling this. This was, again, just weeks after the NFL's new guidelines on this were put into place. And so it just speaks to the need to really practice this, to be sure we have extra eyes on the field. The NFL this year, many of you know, put what we're calling eyes in the sky. We have a certified athletic trainer in the booth of every NFL game that has access by way of audio communication down the sideline of the athletic trainer and team physician on both sidelines, because they can't see everything from the side. You can't see everything from the sideline. And so this is just a way to communicate down when something like this takes place where the medical staff doesn't see them. I'm still not quite sure how they didn't see that. But at any rate, we're going to try to prevent it from happening again. This is another sort of, unfortunately, we've seen a lot of headlines like this. You've heard about chronic traumatic encephalopathy. This is it's been described as sort of an Alzheimer's-like disease, but found in younger individuals. It's a tau protein deposition, unlike Alzheimer's disease, which is a beta amyloid protein deposit in regions of the brain, where this affects an individual's ability to control emotion. It brings on depression. It has created a lot of erratic behavior, and a number of former professional football players, college football players, and unfortunately even deceased high school players that died in unrelated accidents or injuries to this disease, but automobile accidents where their parents have their brains sent to Boston University, to West Virginia University, to now there's a center in Chicago that's doing similar work, and on autopsy finding these tau protein deposits, and we labeled this as chronic traumatic encephalopathy. And this was a case from a former Penn football player that 21 years of age. And so this speaks to what are the late life consequences of these repetitive head insults that many athletes sustain. So again, just one more area. And then I love this quote by Dr. Edward Nichols, Harvard football team physician, really emphasizing the need to take this injury more seriously and to be sure that we remove athletes following this injury. And while there's been this cloud over the sport of football for the last 5-6 years, this quote was made in 1905. Okay, 1905. So something tells me that Dr. Nichols is probably no longer the team physician at Harvard. But very prophetic in that he was taking this seriously, but we've been ignoring it for far too long. And so I think it speaks to the need for more research to be focused in this area. So what is a concussion? The American Academy of Neurology guidelines emphasize that this is a traumatically induced alteration in mental status. And very important to note that less than 10% of all concussions involve a loss of consciousness. But yet there are still a lot of individuals out there, coaches especially, that want to say, well, Johnny didn't lose consciousness, therefore he's not sustaining a concussion. And it's our job, it's our responsibility as athletic trainers, physicians, therapists, whatever your role might be on the sports medicine team, to educate the athletes, the parents, the coaches, that it's more likely that they won't sustain a loss of or experience a loss of consciousness. Likewise, amnesia. What percentage of all concussions do you think involve amnesia? And I have about 3,000 cases that we've studied. 3%? It's higher than that. 67. 67, it's a little lower than that. It's right in between the two.
30. 30.
40.
27%. Who said it? Is that the exact? Yeah. That's probably exactly right between them. About 27%, right on. Okay, so you're good. So again, if you think back to all of the grading scales, that were developed back in the late 80s and mid-90s, up to about mid-90s, they involved loss of consciousness and amnesia as the two parameters that were used to grade concussion. That yet 3/4 of concussions involve neither of those. And so the new grading scales and guidelines focus more on symptom resolution and the duration of those symptoms over time to really grade the injury. So it's just important to recognize this. This is also a functional injury, meaning that we can't see it on imaging just yet, although we're getting better. Diffusion tensor imaging is a new technology that's available that I think in time we'll be able to see. We're conducting some work at UNC on this, and a number of other institutions doing this, where we can look at the white matter tract and the organization of the white matter tracts post-injury within 24 to 48 hours after the injury to try to better understand if we can identify this on imaging. But we have to recognize, and I use this to illustrate why helmets do not prevent concussive injuries. If you think about the movement of the brain inside the cranial cavity, it's a semi-gelatinous structure that sits within the cerebral spinal fluid. And while this is maybe a bit of an exaggeration of the amount of movement that we see, picture this movement. Is a hard-shelled helmet going to prevent that movement? No. A hard-shelled helmet is going to stop those gross acceleration, deceleration type injuries from causing the bridging veins to rupture, or it's going to prevent the skull from fracturing 99.9% of the time. But it's not going to manage the energy inside that cranial cavity in the same way or in a way that we'd like it to. We often use the egg analogy to illustrate this. An egg shell representing the cranial cavity, the egg white representing the cerebral spinal fluid around the brain, and the egg yolk, the yellow, representing the brain. And if we sit here and have an egg toss, every time it leaves my hand, that egg yolk inside is going to accelerate and decelerate when it's caught, right? If we put bubble wrap around that eggshell, okay, because we're backing up and I don't want that thing to crack, and I put the bubble wrap and I toss it, it's probably going to help prevent the eggshell from cracking. But is it going to prevent the egg yolk from moving? No. So the next time you have a parent, a coach, or somebody says, so-and-so's had 2 concussions, 3 concussions, I want to find that concussion-proof helmet. Tell them it doesn't exist. If they're that worried about it, mom or dad needs to find a helmet that looks good on the golf course or the tennis course, because that's probably the sport that their child should be playing if they're worried about that next concussion. So, what are some of the risks of mismanaging this injury? And I think this is why we do what we do. This is why we go around the country talking about this injury and trying to help educate folks about the importance of taking this seriously. There are short-term risks of mismanaging it, and a lot of these just stem from not reporting it. CDC, about 4 months ago, put out a report that said that there is a 60% increase in the number of diagnosed and managed concussions in emergency departments in the last 5 years compared to a 5-year period from 15 years ago. And they were alarmed by this. And I said, this is good news. This is a good headline, and make sure you make it a good headline, because it has to do with reporting. I really do not believe that there are more concussions, true concussions being sustained on our playing fields today than there were 15 years ago. I think we're just recognizing them, we're diagnosing more of them, and as a result, we're seeing a reduction in the number of catastrophic concussion or catastrophic brain injuries due to second insults. And so I think this is good. But why do we want to be sure that we don't mismanage it? Well, obviously, if we mismanage it or it's not reported, then there's the risk of the worsening of post-concussion signs and symptoms or post-concussion syndrome. In our world of sports medicine, we call post-concussion syndrome where symptoms last beyond 3 weeks. If you go to the definitions they'll use in emergency departments and for the standard patient, it's typically more in the 6 weeks or even 6 months, depending where symptoms will last beyond that. In our world, 3 weeks or more of symptoms is a long period of time. That's more of a post-concussion syndrome in our world. School-related issues with the athletes. Obviously, second impact syndrome, where an athlete returns to play while they're still experiencing symptoms from that first injury. The brain in these younger, and typically these second impact syndromes, you may hear these called diffuse cerebral edema, malignant edema, where the brain loses its ability to self-regulate the blood supply. That younger brain can't withstand that second insult in the way that an adult brain can, and we see this diffuse swelling. There's no place for it to go if it's not evacuated. The pressure is not evacuated quickly, and we rupture the brainstem because the cerebellar tonsils get pushed down in the foramen magnum and herniate the brainstem. So that's second impact syndrome. Fortunately, we see, as I've already said, we're seeing fewer and fewer of these in our catastrophic database, and we believe that there's fewer than 6 or 7 of these a year that occur now, that's the good news. Long-term risks, and I'll talk about this toward the end of my lecture, but obviously we still have the risk of prolonged concussion symptoms, increased risk of depression, cognitive impairment, dementia. The CTE is chronic traumatic encephalopathy that I mentioned earlier, long-term academic issues in student athletes. And I think this is one of the counseling points that as athletic trainers and physicians we really need to focus on, and that is that we have to convince these athletes, these young athletes that have already had their second, third concussion, that they're going to be playing sport. Probably on average we play organized sport up until about age 18, 19, or 20. Think about how many years beyond that we have to be contributing citizens, parents, contributors to society, whatever that profession is going to be. And there are a lot of issues here that play into this. So a decreased quality of life, we know, has been reported in a number of studies now from the repeat concussions. But having said that, I wanted to say that I am a huge proponent of keeping our kids active on playing fields, and I'm not one of these folks that's out there saying that kids shouldn't be playing contact sports. It's our job as a community of scholars and clinicians and parents and policymakers to do a better job of putting kids out there and so that they can play more safely. And I think we need to do that, and we can do that. I'm not going to spend a lot of time on this, but I just want to emphasize that this period right after the insult, right after the concussion occurs, is really that critical window. Within the initial 48 to 72 hours after that insult, there's what we call this energy crisis or a metabolic mismatch. It's a period where we have decreased blood flow, decreased oxygen metabolism, but at the same time, a demand for glucose and a demand for blood flow into the area. And this all happens as a result of calcium being sequestered inside the cell. Neurotransmitters are released once the depolarization takes place at the cellular level. And when that happens, potassium leaves the cell, and sodium begins to, the sodium-potassium couple begins working overtime. That brings calcium sequestered in the cell, which really sets off this energy crisis at the time of the injury. And so you can see that by about day 4, on average, this all levels out. And I have to credit a good friend and colleagues of mine, Dave Hovda and Chris Giza from UCLA, that really are the leaders in this area and sort of using their animal models to help us better understand this critical window. And so it's very important. Returning an athlete back to play during this period, this 48 to 72 hour window, even out to 96 hours, is really it's poor management. And that's saying about as nicely as I can say it. And so that's really a critical window that we need to pay attention to. I want to also emphasize that this injury, that no two concussions look alike. And we need to do a good job of being sure that we can identify the symptoms. A couple studies, one of my former students, Scott Kylan, did a really nice study that broke down the 3 sort of areas, and we've begun to group them in this way. If I asked you right now what are the most common signs and symptoms of concussion, my guess is that you're going to be more likely to talk about these somatic symptoms: headache, blurred vision, nausea, vomiting, sensitivity to light, etc., ringing in the ears. But we need to be sure we're not missing the cognitive ones. These are the ones that begin to typically show up within 3 to 4 hours after the injury and last for several days or weeks afterwards. And we have good tools now, concussion tools, to measure this and track recovery following the injury to be sure that we're making sound return to play decisions. And then there's the neurobehavioral ones. And this is sort of can be a vicious cycle here, because these can drive the cognitive issues. The cognitive ones then will oftentimes drive the neurobehavioral ones. These are the ones that we see less often, but these are the ones, when they show up, that we're more likely to develop post-concussion syndrome. The athletes with concussion that have lingering symptoms will begin to develop issues with fatigue, drowsiness, nervousness, difficulty sleeping, or sleeping more. And so this all drives this sort of vicious cycle. So think about them, and I recommend that when you evaluate an athlete with concussion, that you think about it in this way. Focus in on these. They're going to be likely to tell you about these initially, but don't forget to follow up and track these other ones. I've already mentioned that reporting of concussion is getting better, and I think a lot of that's due to the state laws, and I think we're doing a better job with getting this word out. But too many studies from back in the mid-2000s showing that 75% of athletes not knowing the signs and symptoms, over 50% in a paper that Mike McCrane published in 2004, and another one in 2006, showing that over 50% of high school football concussions went undiagnosed and unreported. And the main reasons, saying they weren't serious enough to report, they didn't want to be removed from play, didn't want to let down their coach. And studies that colleagues of mine at UNC are conducting now, and out at the University of Arizona, are showing that coaches, even when they have the knowledge, it's oftentimes not translated down to the level of the player. So it's not just about educating coaches, but it's about transferring that information. The New York Times did a big expose on this and a series of articles over about a 3 or 4 year period. Alan Schwartz nearly won a Pulitzer Prize for his work in this area. And the biggest issue here, high school players shrugging off concussions, and these are real quotes that Alan captured in his interviews of high school athletes. And these are scary. And we need to change the culture because these are this sort of attitude and this breeding this sort of a culture really leads to the catastrophic outcomes. And I think we're making a difference. I tell athletes that don't want to listen to this, I have to tell just a few stories. The law in Texas is called Will's Law because of Will Benson. Will Benson died of a second impact syndrome September 19th of 2002. And this was a preventable injury. Had he been educated about concussion, had his parents known that he wasn't acting right and shouldn't have been back out there playing, but he had that diffuse cerebral edema that I described, and they couldn't evacuate or couldn't relieve that pressure, intracranial pressure quickly enough, and he died. Why are we getting better at doing this? Well, because we have better tools today to do this. And this is a model called using sport as a laboratory assessment model. And I credit Jeff Barth. Dr. Barth is one of my mentors from the University of Virginia, where I did my doctoral work, and he's sort of considered the grandfather of sport neuropsychology. But what Dr. Barth did back in the mid-'80s, mid to late 80s, is he said, we need to get pre-injury information on athletes using neurocognitive tests. And this is really what set off, I mean, everybody today knows about all the computerized neuropsych tests. I mean, Impact was developed 70 miles down the road here in Pittsburgh. There are now 4 or 5 other computerized neuropsych tests out there. We use 3 different ones in our center. And when you use those tools, you can gather pre-injury information in a fairly effective manner. We have added to this toolbox by validating a number of balance tests. And I think that I will say this now, and you'll if you may hear me say it again before I'm finished, but using just neuropsychological tests in your concussion toolbox can get you in trouble. It has to be a multifaceted approach. It's using a combination of symptom tracking, neurocognitive tracking, balance tracking. And if you use that 3-pronged approach, you're going to be much more successful in really understanding and knowing when this athlete is back to baseline. Now, this is just a model of one athlete. It's an example. And this allows us to begin to put this athlete at day 12 on a return to play progression. We don't just send them back to play as soon as they hit baseline. We put them through a progression. I'll talk about that in a minute. And I also love to show this one to coaches who don't want to take the time to get the baseline information, because it's going to take time away from their coaching. So they don't want to take a day and a half to get all the baseline tests done. But more often than you might think, we see athletes that return to baseline by day 3 post-injury. Now, if you don't use this objective approach to concussion management using these tools in the toolbox, then you're only left with one thing, unless you want to find yourself in a major lawsuit, which is to use the 7-day asymptomatic waiting period. Because that's the safest thing, that's what's been published in all the literature by the experts who say, in the absence of any information, you better make sure that they're asymptomatic for at least 7 days, and you reduce your risk of a catastrophic outcome by some figure, 10-fold. You pick the number, different studies suggest it's 10-fold, 15-fold. But why not use the objective testing? Because now here, if this athlete remains asymptomatic for another day, we can start the graduated return to play protocol at day 4. It's not returning back to play at day 4, but it's starting that progression, which could last 2-3 days, and maybe this athlete's back to participation at day 7. But you're making that decision based on, it's a more informed decision. So, we've been tracking clinical recovery, and I know you can't read these numbers, certainly across the bottom or along this axis, but let me just illustrate what I'm trying to share with you here. This is a graded symptom checklist score. So the higher the score, the worse off they are. So this is, at the time of the injury, within 3 hours of the injury, we're showing athletes with amnesia that lasts longer than 30 minutes in the dotted line here. And this is tracking their symptom score over a 7-day period. And so you can see gradually it comes down. Notice that it tracks much in the same way as this line, which represents athletes that had amnesia that lasted less than 30 minutes, but they still had amnesia. And this line here, the dark line, represents athletes that had no amnesia, which we know Represented Randy, or Vince, how many, what percentage of the? 27. The 27% up here. And so this is, the take-home message here is that they track much in the same way. So we should not use amnesia as an isolated predictor of recovery following concussion. Likewise, loss of consciousness, okay, less than 10% here, okay, 90% or more here on the black line that had no loss of consciousness. On this one outcome measure of symptom severity over time, they track much in the same way. There is no statistical significance between these two lines, and I would tell you no clinically meaningful difference between those two lines. So we can't put all our eggs in this basket of loss of consciousness and amnesia and say we're going to make this determination on just these two markers. And then interestingly enough, despite, and this is a large study of 374 concussions. It's one of the largest. This is in review. We're hoping to hear back very soon on this publication. You're getting a snapshot of it ahead of time here. But this group that had 2 or more prior concussions, notice their symptom score is only elevated for the initial 2 data points, so at the time of the injury and 3 hours after the event. So this was surprising to us because we've been saying for years that once you've had 2 concussions, which is that group there, that you're more likely to have a protracted recovery. We expected this dotted line to hang up here for a longer period of time than what it did. So again, the take-home message from this study and what we've written in the comment section of the discussion is that they're all so different. We can't just assume that the threshold for injury for every person is different. And I'll talk about that in a minute when we get to the part on the biomechanics. And then this is on balance. This is on the balance error scoring system, which is if you're interested in, I'm happy to send you the information that we developed this back about 12 years ago. But the big issue has been sex or gender, and we believe that the female athlete is more susceptible to concussive injury. I'll talk later about why we think that might be. Many would say that females are just more honest than males, they're more willing to report it, and maybe more willing to report their symptoms. The females here, they do have a symptom score for a longer period of time, a higher symptom score than males in the dark line. Their balance errors, meaning that their balance is disrupted for a longer period of time, is higher here than the males. However, their cognitive performance on the sideline assessment of concussion or standardized assessment of concussion, they don't score as poor as the males do with the injury and post-injury. So a little bit of conflicting information here, but I think we manage them in the same way. Regardless of whether it's a male or a female, we manage them in the same way. So this is the 5-step graduated return to play progression. And I'm going to leave Michelle with these slides because I realize that I'm going to be on this slide for all of 40 seconds. And if you're interested in this, I'll provide the slides, and if you want to load them somewhere for your students. We're studying this. It hasn't been totally validated, but I can tell you that using this protocol for the past 6 years, we've had all of 3 or 4 cases of repeat concussion. And that's a pretty good track record compared to what we had for 8 years prior to using this or developing this. But this is a 5-step graduated return to play. It would be put into play at that point that the athlete became asymptomatic that I've already mentioned. So we start on that first day with just a 20-minute stationary bike ride, and we're tracking their symptoms while they're doing this. Step 2 then, and this might occur on the same day. We never perform more than 2 steps on any one day, but depending on how they do this, we might move to step 2. Which is more interval rides. We're trying to increase their heart rate, trying to increase intracranial pressure a little bit, trying to see how they respond to this. We then want to track them 24 hours after this as well to see how they're doing on symptoms. If they're doing fine, we move on to step 3 and make this a little more sport specific. And again, we're tracking them while we're doing this, asking them how they're feeling. Exertional step 4, limited controlled return to a non-contact practice. We typically have a day here, or at least a night between step 3 and 4. And then step 5 is a full sport participation in a practice. So this can be, sometimes this takes 5 days. Sometimes this takes 3 days. It depends on how we do with the tracking. So as I've said already, the 5 steps don't mean necessarily the 5 days, no more than 2 steps on any one day. And in general, if these exertional activities do not produce acute symptoms, then they can move on to the next step. It's really important that documentation takes place here. I can tell you that I've been involved with 4 or 5 legal cases where I have represented a team physician, an athletic trainer, a school nurse, and I will tell you that in the 5 cases I've been involved with, that in 3 of them, they would have never gotten to the point that they did. The plaintiffs would have never had a case had they done this. Documentation is critical. And I know that I'm preaching to the choir here, but I was amazed in at least 2 of these cases, the lack of any documentation, and which was what made a case for the plaintiffs. So plaintiff attorneys are very good at making something look like something it isn't. Okay, making just a typical subdural hemorrhage that they tried to convince a jury that it was a combined subdural with a second impact syndrome, that there was malignant edema, diffuse cerebral edema in combination with the subdural, which was evacuated and obvious on imaging and surgery. So because they had documented the step-by-step process, they were able to turn this into a second impact syndrome case. So I just really emphasize that. So know your red flags. I'm going to jump into the biomechanics part of this here in a second and sort of end the evaluation part. But I just know what the red flags are. The typical concussions, 99% of the time you're going to be managing this case that's going to resolve in 10 to 14 days. But occasionally you're going to have this challenging case where symptoms are going to last longer. If they do have an extensive loss of consciousness or amnesia, this might be where you want to image this to see if there's not something else going on. Deterioration over time could be indicative of a slower bleed, a slowly developing subdural. Epidurals typically, because it involves an arterial bleed majority of the time, will be it'll bleed out more quickly and they pick up very quickly because they deteriorate and go into this sort of state of unconsciousness. But the subdurals, there are reported cases in the literature of subdurals that develop over the course of not only hours but over days. And my guess is you've seen some of those. Those are tricky because they can be missed fairly easily. So anyhow, these are the things you want to look for red flags, and this is the sort of what the epidurals. I'm not going to go through an anatomy lesson here, but again, a more quick bleed, the subdurals, a slower venous bleed, and then on rare occasions we'll see these, the subarachnoid hematoma or the second impact syndrome that I've already described. So this is, I've often said that this is sort of like piecing together a puzzle. Managing concussion is like piecing together a puzzle. We image probably 1 in 12, 1 in 15 of the concussions that we see at UNC. And those are the ones where there's these red flags that are there. We say, we need to check this out, there may be something else going on. If you take a good look at the mechanism, if you conduct a good, solid, sound physical exam and you do serial exams, tracking symptoms, postural stability or balance, cognition, and have an understanding what their concussion history is, and you piece this together and you manage it effectively, there's probably no need to image it. Okay, I've already said that this is a functional injury, which is what all these things allow you to do, is to track the functionality of that injury and what's happening, as opposed to the structure, which 99% of the time there's nothing there. So it's sort of, we describe it as a concussion puzzle. Okay, so on to the biomechanics of this. And the PETA group doesn't like this slide, but we say they're wearing a helmet, okay? So everything's good. So what causes concussion? This is described sort of as this concussion equation. And everything I've talked about to this point, we have focused on the sort of the right-hand side of the concussion equation, all right? We've done and not just our work at UNC, but there are a number of groups around the country that are doing really good work in this area of providing recovery curves for us on symptoms, neurocognitive function, balance, better understanding the chronic effects. We need to continue doing this work, but I think that we have neglected the left-hand side of the concussion equation and trying to better understand the impact biomechanics, how often impacts occur, what the linear acceleration looks like, the angular acceleration, the more common locations of these injuries. If we do this right, we can begin to quantify exposure. Maybe we'll find out how many or too many that puts individuals at risk for the chronic injuries that I've talked about. 2 years ago, I was asked to join the NFL's concussion committee. And I, for many years, was an outspoken critic of the NFL and the way that they were handling concussion, along with Dr. Bells, who many of you know. Dr. Bells, who was the chair of neurosurgery here for a number of years, is a good friend of mine. And we were critical because they had a committee that was ignoring this injury. They were shoving stuff under the carpet and saying that there are problems. And now you see, it's rare to pick up a newspaper in a given week where you don't hear something about a class action lawsuit about where former players are suing the league for having mishandled this for many years or ignoring some of these issues. And when I was asked 2 years ago to join the committee, I made it clear that I would join that committee, but I would still be a critic if I felt I needed to be a critic. And they still brought me to the table. So I have, someone suggested maybe they had been in ahead a few times. But we're working well together. And it's because I think, and it's not just me, there are a few others that have brought to the committee that were also critics of the way things had been done. And I think that I will say Roger Goodell, and he's had a heck of a week, hasn't he? He's doing a good job. I think he's doing a very good job. He's taking this seriously, and I think when his tenure as commissioner of the NFL is over, whenever that is, and I hope it's not anytime soon, his legacy will be that on player safety. Because let's face it, there's a major public relations problem for the NFL right now. But I think he's doing everything he can do to try to move in the right direction. One of those is that he's agreed he wants accelerometers in the players of every football player in the NFL. And so we're developing the same protocol that we've been using at UNC, and they've been using at Virginia Tech and at Oklahoma and at Dartmouth and a number of other places over the past 8 years. And I really think that we're going to learn a lot about how we quantify exposure and try to help the helmet manufacturers learn about helmet design and open field versus interior line play and special teams plays. And the kickoff rule change this year in the NFL was a result of the accelerometer data from our center at UNC. And I'll explain that to you in a minute. Devin Hester did not like our kickoff rule change, by the way. But I think he still returned a few kickoffs for touchdowns. The middle of the concussion equation is also an understudied area, and I hope that we'll learn more about it in the next few years. But we need to find biomarkers. The military is very interested in biomarkers so that they can understand how soldiers on the battlefield respond from blast injuries or from blunt trauma injuries that we can pick up, by way of a blood draw or a cerebral spinal fluid draw to be able to identify that this is an athlete has been, or this soldier has been concussed, and I think that we can translate that over to the athletic setting maybe to better understand the degree of injury that they may have had. There's a lot on treatment and rehab of concussion, and omega-3 fatty acids have been proposed as an intervention and has a neuroprotective effect. This has been only found in animals. There are no human studies that have proven this, and so while I'm optimistic that we can get there, I'm worried that we're moving a little quickly and that there's some false advertising out there on omega-3s. And so I caution you that when you have a parent, an athlete, a coach that wants to pump Johnny up with 3,000 milligrams of omega-3 with DHA in it every day because it's going to help me. I think probably not going to hurt Johnny, only if he has a false sense of security, thinking that I'm not going to have another concussion, so I'm going to, pump myself up and go out there. So that's my line on omega-3 fatty acids. Not everybody agrees with me on it, but I believe we need to have the science there before we're going to put it out there. claim that it's going to do what they're claiming that it does. Hyperbaric oxygen treatments is another proposed, so oxygen saturation. My guess is there are a few Steelers fans in here, right? I hope so. I am as well. Heinz Ward is the biggest proponent of hyperbarics. It cured everything for him, right? And you know what? There may be some truth to it, but again, there aren't good human studies yet to suggest that it can treat the effectiveness of it for treating concussion. I hope someday we'll be there, but we're not quite there yet. And then the most recent one is progesterone treatments post-injury. This is within the last 8 months has been proposed. There's a really good group down in Emory in Atlanta that's studying this, and so I don't want to sound as a skeptic. I just caution people that we're moving a little fast in some of these. I hope that we have good data soon to help us here. So I want to show you a video of what got us interested at UNC, and this is a game between Arizona and Oregon from about 9 years ago. So this is an old video. You're going to see Joey Harrington as the quarterback. So that helps date it. It may be more like 10 years old. Somebody probably can Google it and tell me that I'm wrong, and maybe it's 11 or 12 years old. But this is what sort of got us started, and I want you to watch what happens here. They were part of a study. University of Arizona is in white. They were part of this study, and that I was conducting. We had 45 Division I colleges in this study, and we'll show you this, and we'll slow this down and show it to you in slow motion here. But the team physician from University of Arizona sent me this video footage, and he said, "You're not going to believe this," and I'm going to say that you're not going to believe this till the end. But watch number 8 here. He gets lit up. Notice he's not paying attention here. He's looking one way, and look what happens. Hello. Mouth guard goes flying.
The angle. Oh,
You're going to see the athletic trainers on the sideline here now fixing up. He had a through-and-through laceration of his lower lip. Okay? And about 20 minutes later in the same game, you're going to see another injury. There's Joey Harrington. And I want you to watch this defensive player for Arizona in white. He's going to make a nice play, and his teammate's going to chest butt him. Watch what happens after he's chest butted. You see his head rebound off the turf? And that's the old artificial turf at that time. And they'll show a replay here, but unfortunately it doesn't show that sort of whiplash rebound effect as well as it does in the first one. Note to self, do not let my teammate chest butt me. So clearly, the first one was more serious, right? That's what we all thought, but no. The first one didn't even result in concussion, believe it or not. Through and through lip laceration, probably would have gone back in, but they took him across the street and stitched him up apparently. And the second one resulted in a grade 2 concussion and missed 2 weeks. So we can be fooled by what we see. And so that led us, I had this video footage, we had video footage on all these concussions over a 2-year period. And I said, we need to better understand this. So we pitched this idea to the CDC to fund our work. And I met, I was in a meeting in Puerto Rico and met Rick Greenwald, who developed these head accelerometers for helmets. And he was down there speaking at a military meeting, and I said, we got to put these things in football helmets. And he was already developing a prototype for it. And so we did this, and I'll show you to you in a second. But the questions we wanted to know, for those in a room that are researchers, it always comes down to the research question and formulating good research questions. So is there an acceleration tolerance level for concussion? So can we identify the amount of acceleration as measured by G's of linear acceleration that it takes for an athlete to sustain a concussion? And if so, what might change that tolerance level? The location of the impact, their concussion history. Does someone with 3 prior concussions only need to be hit at 40 Gs, as opposed to somebody who's never had one perhaps needs to be hit at 80 Gs to sustain a concussion? the history of subconcussive blows. So our offensive and defensive linemen that take an impact on every single play, more susceptible to concussion, or is their threshold lower because of those repeated insults to the head? Or playing position, or age, or what might modulate this? Does clinical outcome correlate with impact severity? And I'll tell you the answer to this is no, because I don't have a slide on it, but the harder impacts do not result in greater cognitive deficits or greater balance deficits or worse symptom scores. Okay, there are 3 studies now that have shown this, so it's not about how hard you've been hit. I think that video that I just showed you sort of illustrates that, that point. Can tracking impact biomechanics influence or change behavior? I am going to show you 2 slides on this because I think this is important. So, this is what the head impact telemetry system looks like. I cannot take credit for developing it. This was a good friend, Rick Greenwald from Simbex, which is a company up in New Hampshire, and he's affiliated with Dartmouth. But these are 6 single-axis accelerometers that sit within the open space of the padding, and they work they communicate together by way of an algorithm that I couldn't explain to you if I had 5 semesters of physics in front of me or behind me. But they work by way of a radio frequency. This is a receiver that sits on the sideline that's connected to a laptop computer. And by way of radio frequency, we register every single impact on every player in real time on the sideline. It takes about 3 or 4 seconds after the impact for it to be registered on the sideline. And we measure it in G's of linear acceleration and radians squared for angular or rotational acceleration. And what we've learned, we now have been doing this for 8 years, but this is the published data. After 6 years, we now have about 320,000 impacts. And on average, players withstand about 950 impacts a year, on an average about 24 Gs of acceleration. And you might be sitting there saying, well, fighter pilots, they pass out at about 8 or 9 Gs when they're rolling out of a turn. You've seen them in the movies. The problem is that they're withstanding that 8, 9 G insult for a long period of time. They're rolling out, it's taking 4, 5, 6, 7 seconds. These impacts are within milliseconds, about 8 to 10 milliseconds of time. So just a fraction of the time that those fighter pilots experience that they pass out and then come to. So what we're worried about here, though, is that they seem to do just fine. The brain can withstand the 950 a season, but what happens later in life when you've been playing the sport for 4 years of college, high school, 4 years of college, 6, 8, 10 years of professional football? These add up, and what do we look like at age 50, 60, 70? And I'll share a bit of that with you here in a second. The last bullet point here is that what we found, an interesting finding, was that when players, during helmet-only practices, so these are sort of your skeleton practices, where they're not wearing shoulder pads, not wearing thigh pads, that for some positions, these light practices, the impacts to the head were actually, they registered higher on average than what they did during regular practices. Meaning that when all you have is the helmet, you're going to use it. So this is where the Ivy League's they're changing their rules, they're limiting their contact practices, or taking helmets off of them for certain practices, and we may be headed that direction. I think both the NCAA and the NFL may be headed in that direction. What we have found after these 6 seasons of capturing data, that about 15% of the impacts are to the crown of the head. In my opinion, this is still too high, because these are the ones that load the cervical spine. These are the ones that have the highest impact magnitudes because of the load that it takes, because you have the whole body there that force it against that impact. About 16% of them are to the either side, but surprisingly, the majority of them are to the front and to the back. And this was a surprise to us, but a lot of these are rebound impacts where somebody's impacted from the front, so they get an impact here and then an impact on the back. So one play might result in a front and a back impact. So you get sort of that coup contra coup effect. So that's what we see with that. Leading with the head is still a problem. And this, as I've already said, 15% of all impacts over 6 years were to the crown of the head. And what we know is that these crown impacts are more likely to sustain impact over 80 Gs, 3 times more likely than to the side or to the front or to the back. And what's interesting is that when we average, the good news is that we're moving in the right direction. After our first 3 seasons, we had nearly 20% of all the impacts which were the crown of the head. But it was at this point, after the 3rd season, we started this behavior modification program that I'm going to talk to you about. And as a result of that, we've been able to drop that 19% down to 15%. So I think that's the good news. I will tell you that special teams and kickoffs are the most, punts and kickoffs, which both are special teams plays, are the most dangerous plays in football, especially at the youth level. Most of the catastrophic injuries, subdural, epidural, hemorrhages that we see in football players occur, a disproportionate number of them occur on kickoffs and punts. And the physics are just are greater in these injuries. We see more players that are they're ill prepared to take a hit. They take a blindsided impact on those plays compared to the others. So this is a problem. Let me show you an example of one of these. This is in a practice, and I want you to watch the player to the right of the kicker here run down and make contact with his head. And this registers, as you can see, at 157 Gs to the crown of the head. This player right here. In a practice. And you'll see it from this angle here again, this player right here. So we take a player like this and show him the video footage, show him his profile for a practice, a series of practices combined. We can collapse all the impacts at one time on one image, and we try to change their behavior.
Lucky he didn't break his neck.
He's lucky he didn't break his neck, you're right, because that's an axial load and it's not good. Which is exactly what happened to Eric Legrand, the player from Rutgers last year. It was on a kickoff, lowered his head, and we actually have video footage from that, from the games leading up to that play. He had a history of doing this, and our special teams, our graduate assistant that breaks down game footage to help us prepare for games, had seen this. And when we heard that a player from Rutgers had had a cervical spine injury in a game, he said, "I bet it's number 50. I bet it was number 52." I mean, it was kind of just sort of eerie that these things could be picked up, but in that case, it wasn't. So, special teams plays. This is where the NFL was very interested in these data. I presented it to the competition committee in February about a year ago, and as a result, we changed the kickoff rule because. And I will say they wanted to change the rule, but they had no data to support a rule change. But you can see, on average, the linear acceleration on special teams, and these are primarily kickoffs here, is greater than any other play, even a defensive play where the closing distances for the defensive player and the offensive player are greater than 10 yards. And this paper was we published this actually a few months ago in the Biomedical Engineering Journal. This is, again, just one way that we can study this. And the kickoff rule, for those of you that know, we moved it up 5 yards, so we're seeing more touchbacks this year. And no more than a 5-yard running start for the kickoff team. So it used to be that they could line up 10 yards off the ball, the kickoff team. Now they can only line up 5 yards off the ball. So we've minimized the physics that's involved with those collisions, as well as just limiting the number of return balls. So as a result, we saw a 42% reduction in the number of concussions on kickoffs this season. So I think that's one example of how we can change the rules. Majority of concussions in our study occur to impacts the crown of the head, and we know that you're about 17 times more likely to sustain a concussion if the linear acceleration exceeds 100 Gs. So is this the threshold for concussion, which was one of our first research questions? No, because we see players that sustain concussion at 60 Gs, And we see some players that are impacted at 115 or 130 Gs that don't sustain a concussion. So what we know is this is sort of an elusive threshold for concussive injury. So I mentioned behavior modification, and I'm going to start to wrap this up. But I want to give you one example of how behavior modification can work. And this isn't a game. We had a player, and again, it happens to be on a kickoff. And I'd like you to watch this player right here. He's going to lower his head and impact the right side of his head right there. That was 102 G impact that took place there. And we noticed that, and this was his second concussion of the year. He had one during camp about 9 weeks earlier. And we said, so we started looking at his profile, and we said, here's some game footage. This is what your game footage looked like here, and then this is what your profile looked like for just one game. 31 impacts to the head. And so we started this behavior modification program, saying that we can teach, say for football, by showing them the game footage, showing him his profile, sitting with his position coach, developing some drills for him during the practice. And imagine if we can do this with Pop Warner football players, where that's where skill is developed, and we begin to develop bad behavior and good, hopefully good behavior. Sort of what we're after here. 4 weeks later, after that concussion, we bring him back, and he's playing. And this is him right here. And I want you to notice what he does on this kickoff. We'll show it to you in slow motion. But he rotated his head out of the way and impacted with his left shoulder. So it's just one case, but we now have probably 8 or 10 cases where we've been able to change somebody's profile and we show what they look like after this intervention. And so I really think that behavior modification strategies are perhaps more important than going after chasing down the helmet, the concussion-proof helmet. We're doing this in ice hockey as well, and I think that we're making a difference. This is my colleague Jason Mihalich. This was published a few years ago, looking at the effect of collision type and player anticipation on head impact. And what we found was that open ice collisions, this is in youth hockey players, resulted in a higher linear and rotational acceleration versus collisions along the boards. Not major differences. You might say, well, what does 1 G mean, or what is 200 radians per second squared mean? Probably not a lot on one hit, but add that up over the course of a season or a career, and I guarantee it means something. So that's sort of what we're after. Unanticipated collisions resulted in a higher linear and rotational acceleration compared to anticipated collisions. So teaching kids, and that sort of was a take-home point here, teaching youth athletes the technical skills to heighten their awareness, create an environment where they know when they're going to take a hit so that they can tense the neck muscles and withstand that impact better. So that's sort of what we're after. The biggest challenge is how do we manage the energy to prevent both concussion and severe TBI. The NFL, I will say, before we started working with the committee, they were doing some good work of analyzing game footage and identifying that the struck player, sometimes we call this the hammer and the nail. You'd much rather be the hammer than the nail, right? More than double the linear acceleration by the struck player compared to the striking player. Some of our more recent data on kickoff suggests that we're narrowing the gap on this, that these striking players, I know Steeler fans weren't proud of this, but this is the problem in the NFL, okay? And the problem is, my goal is that nobody here will get a headache from watching this. I'm a huge Steeler fan. My parents were sitting back here and they can attest to the fact that I'm a big Steeler fan. So I can't say that I'm a big fan of how James Harrison plays the sport of football. And you can see that Colt McCoy here is like that bobblehead doll. okay? That is a high acceleration injury there, even though he claimed to have a hand injury when he came off. We were wondering if it was just his Texas accent when he came over and said, it's my hand, it's my hand. And he was saying his head, but they thought it was his hand. But at any rate, he had a concussion, it was mismanaged, and this is why we need to do a better job and focus a little bit more on the strengthening of the cervical muscles. If you take an insult and you think about the center of mass of the head being this small red dot, and the red ring representing the acceleration, this is what happens when the neck muscles aren't contracted, where they can help manage the acceleration of the center of mass of head here, of the head. What happens when we tense the neck muscles is that we shift the center of mass of the head down through the neck and down more toward the shoulder. And this gets back to technique and teaching young kids how to develop better technique. When we do this, we increase the effective mass by 2/3, and this is making the head, the neck, and the shoulder one, as opposed to that bobblehead doll, and the center of mass is up here. When we do this, we shrink these red rings, and the acceleration of the head is reduced. And while I'm not a fan of rugby, I will tell you that they're much better at this than football players. And I'm not saying I don't like rugby, it's not a sport that I have studied or that I understand, but this is an example of what I mean. The head, the neck, and the shoulders are one when he's making that tackle, which is why we see, in my opinion, fewer concussions in rugby than we see in American football, and we need to be more like this. So, why are some athletes at a greater risk? Well, females, we do believe that it has something to do with cervical neck strain, and they exhibit greater head acceleration with the decreased neck strain. This has been, there haven't been good studies to show this yet, but we think that there's probably something to this. Females are, they do report concussion more often as well. So I think that's part of this, is multifactorial. The youth athlete, thinner cranial bones, larger head-to-body ratio, reduced neck strength, all factors here. And I think this is why we see probably an increased risk in the youth athlete. Having said that, I've already said I am a proponent of putting youth athletes out there, teaching them how to do this right. These are my 3 sons, all who have played football. This is an old photo, but Jacob, who's now 15, is sitting over here with my parents and is a huge West Virginia Mountaineer fan and hopes to be a Mountaineer someday. So he's going on his first college tour tomorrow at age 15. So I hope that maybe he'll be part of the class of 2019 or something like that.
Yeah.
So with that, I'm going to stop and take questions. So thank you.
Any questions?
Any questions?
Any questions?
It's late in the day, I know. And there's basketball. I'm sure that my son, he can probably give you an update on the scores.
I work as an athletic trainer in Pennsylvania, a lot of UPMC, and UPMC, their big thing is they're reducing a bunch of schoolwork and such as significantly the last 5 minutes early and stuff. Do you think, have you seen any of that or see anything?
Yeah, so certainly University of Pittsburgh has been one of the leaders in this, and they have done a good job of focusing on academic accommodation. And we need more research in this area of academic accommodation. And I have my talk tomorrow with the group. I'm going to focus a little bit more on that and talk about some of the strategies, which is teaching more in block learning and reducing the time in the classroom. there's a number of strategies, and we can learn a lot by neurocognitive tests and the different domains. That's the beauty of neurocognitive testing, that we, through the different domain scores, we know whether they're having a working memory problem, whether they're having an attention span problem, whether it's visual spatial, and we can then adjust and make those academic accommodations based on what we find from that testing. So I'm a big proponent of that, and there needs to be more published data on what really is working in the way of those interventions. But that's great. And does it seem to be working for you in your setting?
Yeah, and the few we've seen, it seems to, so they're more like, they've been more like long-term, bringing stuff before than it's reduced more and more.
Have you ever heard of the REAP program that's out of Colorado?
Yes.
And are you a proponent of that, or?
Yeah. So it's an acronym called, it's REAP, and I can't remember what it stands for.
And I can't remember either, but it's more of an educational program for communities, families, and it's primarily for like middle school, high school kids, so
Yeah.
that the families become more, and physicians and stuff become more educated about concussions.
Yeah. So there have been a number of concussion education programs. The CDC started this probably 10 years ago with putting out concussion toolkits. Colorado's done a great job. Theirs, it really has been timely in that a lot of the state laws are being passed, and they're developing that program in concert with those laws. And I know other states have adopted that REAP program for Colorado. But it's about getting in the hands of middle schoolers, high schoolers, the educational materials. And I haven't looked at the map lately, but I can't recall. Does West Virginia have a law yet? No.
That's funny you mention.
It was in the legislature 2 weeks ago, a week and a half ago.
And it didn't.
House and Senate voted unanimously. And the bill was killed because of language.
Okay.
So, but they were hoping that perhaps get it in any special session sometime this summer.
Okay. I had heard a rumor that it was maybe going to struggle, and you'll get there. We had language issues, and ours was just passed in June of this year. Or of last year. It's frustrating. I know Pennsylvania, I helped them back, theirs was passed, I think, about 3 months ago. But you'll get there. I do think the state laws will save lives in the long run. I think that we have to, the reason that we have the state laws right now is that the education alone, to put it in Stan Herring's language, Stan Herring is the physician, Seattle Seahawk physician that championed the Washington state law, Zach Lystat law. And Stan has always said that the education alone, it's not the stickiness of just isn't there, that the law really needs to be there, because if you have the right people policing it, people are going to follow it, and it's going to get out there. So I hope that you get there. I highly recommend the REAP program if you go in that direction.
I have a quick, it's a kind of a clarification question. You said something about 60% increase in reported concussions in 1 year compared to the past 5 years. Is that correct?
So, no, almost, real close.
Okay.
So there was a CDC report that was a 15-year study.
Okay.
And what they did is they looked at the last 5 years compared to the initial 5-year window, and found that there was a 60% increase in treated and diagnosed concussions in emergency departments during this 5-year window compared to that initial 5-year window.
Okay.
And I said that was a good, that was good news, because I think that, yeah, you got it.
Okay.
You're nodding your head, I take it you got it.
Yeah, I
Do you agree or disagree with me?
I agree with you, but that leads
But, there's
that
no
leads
but.
me to my
Next
actual
question.
That leads me to my actual question. Do you feel that emergency medical physicians are properly educated and informed on current concussion management procedures compared to physicians who, 5 years ago graduated?
Yeah, so I would hate to generalize. Have I seen emergency room physicians who are very good at this? Yes. And I've seen emergency room physicians that I wouldn't let my kid anywhere near. But I've seen family physicians and pediatricians and believe it or not, neurologists, many neurologists that I wouldn't let my kid near, because they don't do this on a daily basis, and they don't stay up with it. So I hate to pick on just emergency department physicians. Let me say this though about emergency department physicians. This is what I found. and we actually have a small study going on in this area, is that they do a very good job of ruling out the traumatic event, the bleeds, and that's usually what they're focused on. When they have an athlete or an accident, they know a patient from an automobile, their primary job is to make sure that there's not a bleed there's not a skull fracture, that there's not something that's going to lead to a serious outcome. What I have found, again, is that they could get better at the counseling from that point and getting them in the hands of the right person. And the state laws, I think, might help with this. But I had a case, this wasn't recently, this is about a year and a half ago, a mother that said, yep, I took my son in, and they ruled out everything, and the emergency room physician said he could go back on Tuesday. I said, really, what's unique, what's Tuesday mean? Is Tuesday, what's a special day? So I always say, we cannot manage these injuries. We have all these good tools that have been validated. A calendar is not one of them. We should not manage concussions with a calendar. Other questions?
What are your thoughts on the best healing environment post-concussion? I know things have changed over the years from wake somebody up throughout the night to let them sleep, stay away from brain stimulation like watching TV, playing video games.
So great question. So we are no longer recommending the wake-ups at the middle of the night. In this case, this has come out now in a number of position statements. That was 20 years ago. We were saying wake them up because too many of them weren't being sent for evaluations. If they had a period of loss of consciousness or a lengthy period of amnesia, or they were deteriorating, those folks weren't getting, unfortunately, sent to emergency departments for observation or admitted. So we sent them. You would send them home, and the parents were told wake them up every 2 or 3 hours. Well, for what? To make sure they're breathing. Well, you can make sure you can make sure that they're breathing without waking them up. Waking them up causes all sort of sleep deprivation issues, cognitive challenges the next day. So we're not recommending that. We're also not recommending any meds during the initial 48 hours, so that we don't mask something that might be important for picking up one of those red flags, which was a deteriorating condition. So we try to avoid the meds during those initial 48 hours. And if we are going to give them something to sort of just take care of that headache that seems to be problematic, it's acetaminophen, Tylenol, not aspirin or ibuprofen, to some of the platelet issues that might show up there. Again, a couple papers were published on that. But and then your question, the rest of your question, I think, was centered around sort of stimulation. How much is too much? And there was a football coach at Texas Tech that was using cocoon therapy. They put him in that shed for. We don't recommend that. He got fired, although I think he's just been rehired somewhere. There are some suggestion that bad jokes. It's about spring break, so I can use bad jokes, right? And it's late at night. But there's nothing really to suggest that there's a physician up in Connecticut that has suggested cocoon therapy, that total removal from activity and any sort of interaction, no TV, no interaction for 24 to 48 hours. I don't know that there's anything to suggest that there's a better outcome after that injury. The only study that's been published on this was one out of the University of Pittsburgh about 4 years ago. It was a retrospective look at 4 different groups, and there were the 2 extremes. The one group that went back quickly, another group that was pretty much total bed rest, and the 2 middle groups where there was moderate levels of physical activity or moderate levels of cognitive activity. And it was those 2 middle groups that performed best in terms of cognitive scores and symptom scores outwards of a few days or a few weeks post-injury. That's a real rough summary of that paper, but I think we just have to be smart and manage them each individually.
Another question, regarding the individuals that have like, the prolonged cognitive, the prolonged kind of emotional type of disturbances, maybe depression or anxiety or whatever that may follow this. Is there any recommendations with follow-ups where they receive additional counseling or psychological care as opposed to just getting physical treatment from the physician
Yeah, so again, access to those sort of resources, I think, we're seeing more of it. I have, tomorrow I'm going to talk a little bit more. I mentioned some of the work we're doing with retired NFL players, and we know that those with 3 or more concussions during their professional playing career are at a 5-fold risk of non-cognitive impairment and at a 3-fold risk of depression, being diagnosed with depression after the age of 50. And I'll probably talk a little bit more about that tomorrow. And we have imaging studies now that are showing that same group that we're seeing changes on diffusion tensor imaging and volume changes, believe it or not, at age 50 to 60, which we don't usually see volume changes until 72 to 75. So I think identifying these things earlier in these athletes in high risk so that we get them into the right type of counseling and treatment. We're working on a program with the military following blast injury, looking at dual task therapies. So combined cognitive therapies with movement. So it's putting them in a virtual environment and asking them to think and move at the same time. And I think that's where I think that we're going to see some success in those younger athletes that we're trying to get back to playing, that they have post-concussion syndrome. The good news is that only 5 to 8%, if you look at the studies, and there are a number of them, the American Academy of Neurology will have their new practice parameter coming out hopefully by September. And you'll see that only about 5 to 8% of concussed athletes develop post-concussion syndrome, which is that 3 weeks or more. So it's those are the ones that really warrant what you're describing. 90% of 95% of them are going to recover fairly quickly. That's the good news.
Yeah, switching the theme a little bit to sort of just social awareness. We talked about protecting and educating youth in the proper way, and we've seen sort of a rise in Play 60 commercials, through the NFL for childhood obesity. Do you think it would be at all effective to start releasing public service announcements, and if so, how effective would they be, and who would you target?
Yeah, another great question. I think what's important is that while there's been this cloud over the sport of football, concussions occur in all sports. Certainly football has the highest incidence rate when we study it by athlete exposure. But, and what I'm worried about is that we're all this bad headlines is pushing more and more of our youth out of organized sport. And we're going to end up with a fat society, or a society of fat kids. And back in '96, and some would say we're already there. I think that's what somebody just said here. But it can get worse, I guess. Back in '96, the Surgeon General made this was this exercise medicine campaign that the Surgeon General put out at that time, and where we were trying to push more kids into where childhood obesity and diabetes were at its peak. And so what we failed to do as a society, I think, is what you're describing. And that is, we said, let's just push everybody into organized sport is going to cure these diseases or prevent these chronic diseases. But we weren't smart about being sure to keep in check that increasing risk of injury when you're taking somebody who has never played football or soccer or what you name the sport and pushing them in there and seeing the injury. So I think the answer is yes. I think the NFL is doing their part. I think the other sporting organizations, the NCAA, the National Federation of State High School Association, they all need to step up to the plate to be sure that we're doing this. But I like the public service announcement that they shouldn't just focus on football.
I just want to say thank you for your presentation. Really enjoyed the conversation there. At what point, I'm looking more of an Appalachian culture thing right here. There's a lot of bad people right here. But a lot of education issues as well. And when you look at high school sports in rural Appalachia, I see people going into a sporting goods store saying, oh, I'm going to buy this strength system because I'm gonna set the football guys up on a strength program. Where are the certified strength and conditioning specialists at this point? Why have we not, or do you know of any high school systems other than ones that are affiliated with, Nationwide's Children's Hospital, or any clinics hospitals like that, that have a multidisciplinary team approach, where, you know, you have your ATs, you have your team physicians, you have a strength coach, you know, somebody who actually knows what they're doing. You have that guidance counselor or the school psychologist. Are there any high schools, I guess, county-wide or anything like that, you know, of that use that NDT approach? Because I think that might be more effective than putting the entire burden on the athletic trainer.
It's a great point. I don't know of places that are doing that. Obviously, a lot of it has to do with available resources, and so I worry a lot about the rural communities that don't even have a certified athletic trainer as a point person. And the good news is that I think that's the person that has to be the quarterback of all this, and they're the ones that once you have a certified athletic trainer, you're going. I'm curious, where in West Virginia do percentage-wise of secondary schools with certified athletic trainers? Do we know?
It's like 65.
65, that's great. You're above the national, the national average is just approaching 50. Is it that high? Yeah, that's, I mean, there are, I mean, some states are at 95. I mean, New Jersey is at 100. Pennsylvania is probably at 85 or 90. Texas.
He's our Texan.
Are you? He didn't like the Colt McCoy joke.
He liked it. He smiled.
Sorry about that.
He liked it.
But yeah, they have their own. They're their own country, aren't they? They have, they
Mexico
have their
and
own certification. They don't even recognize, I don't think, the VOC.
Recently, we're starting.
They're conforming, and that's good. But at any rate, to get back to your question, I worry that I think the state laws are going to help. In North Carolina, we've been way below the national average at about 33% of schools. We're now at about 39, 40%, just in a matter of two or 3 years because I knew the state law was coming. But I think strength and conditioning coaches at the high school level, I think 90% of the time you're dealing with a coach, you know, a sport coach, the football coach, the basketball coach, the wrestling coach. And the question is, what certifications do they have? And I worry that we use, I can tell you, I just attended in Colorado Springs about 8 weeks ago, we held a summit on this. It was all about surrounding strength and conditioning coaches, and the NCAA was there, the National Federation of High Schools was there. You know that there have been 23 football-related deaths in Division I football since 2000. 23 deaths. And 2/3 of them were training-related deaths that took place on the first 2 days of training. And we had strength coaches getting up and talking about this fear-driven industry that they work in because they're hired and fired by head football coaches. And that is a major problem. And I realize you were asking me about high school, and I'm sorry I'm going in another direction. But that's who we look up to. We look up to what's happening at the collegiate level, who looks up to how it's being done at the professional level. And so there's this trickle-down effect. And granted, it's a resource issue at the high school level, but we don't have enough trained. And a lot of these head football coaches, they're not hiring certified strength and conditioning coaches now because they want another, they're limited, the NCAA is limited the number of coaches they're allowed out there. So they hire a former defensive line coach to be the strength coach who has absolutely no certification, including in first aid and CPR. I couldn't believe the stories that we heard at this summit that was held. And so until there are mandates by the Federation, National High School Federation, and the NCAA that says that they shouldn't be hired and fired by their head coaches, I think we're a long ways off. So I'm rambling, and it's getting late. So I'll take one more question. If there's another question, and then we'll wrap it up and go watch basketball.
So, I feel a little awkward because I'm the probably medical person. I am the pediatric trauma coordinator for the hospital. And a lot of people don't realize that we, state of West Virginia, also, we have a trauma registry. So any patient that comes to the hospital, we submit to the state and to the National Trauma Registry. The big issue that I'm starting, because I'm going to start some outreach here in the state, is I get the information from the hospital standpoint, but because of HIPAA, I cannot call the football coach or the athletic trainer and say, hey, this person was in a car accident, they sustained a concussion, they need to be evaluated. So
is there any states, like in state laws, that can help regulate, like allow us to do that?
Yeah, I see the challenge there. I mean, because you're saying it's a non-sport related
Right.
concussion.
But then they return to
And they-
practice 2 days later.
And they're not forthcoming
Right.
in that information. Yeah, that's a challenge. I had not thought about that. I mean, the good thing of all the state laws is that the 35 that now have been passed are, and there's 7 or 8 more that are pending. They all have not only the educational component, but the clearance by a allied healthcare provider, training concussion management. And that athlete has to sign off. Now, what might work, I don't know. Again, it comes down to how honest they are. But in North Carolina, the parent, the athlete, have to read the signs and symptoms of concussion that are not only sport related but non-sport related, and sign a waiver saying that they understand it's their responsibility to report that to their coach, athletic trainer, or administrator. And there's a whole, and it's on file at the North Carolina High School Athletic Association. And so if they were to find out somehow that they had had that injury, but it went unreported, it would come back to them, and that parent is in non-compliance of the law. Our law is called the Gaffeller-Waller law, after Matt Gaffeller and another deceased player that same year. So that would be the only way that would indirectly get at it. So I'd encourage you, if you're looking at your state law, and I don't know if there are people here in the room that are helping with that you have that sign off. And all the documents are on our website, and there are some other states that have adopted some of our materials, and all the documents are printable off of PDF. If you just Google Gaffeller-Waller law, it's there. And so I think that would be how you would get at it indirectly. So good luck. I hope that you can do it, because it's important. Thank you. It's been great.